Good morning. I'm Tabassome Simon. I work in Paris, France, and I'm very honored to talk about our trial called Reality on behalf of all my colleagues and investigators, and in particular Gabriel Steg, the PI of the trial, as well as Grégory Ducrot, the French PI, and Dr. Juanate from Spain. Reality the rationale of this trial was based on the fact that anemia is very common and a frequent feature in patients with myocardial infarction. And so today there is really an equipoise for physicians who are in charge of these patients and whether they should transfuse these patients with a liberal strategy or a restrictive strategy. And there are many trials which has been done in other settings, but in MI, there are very, very few randomized trials, and there are actually two with a very small sample size, and they're completely contradictory. One has shown rather a harm from a restrictive strategy compared to the liberal, and then the other one exactly the opposite. The liberal was less good in terms of MACE compared to the restrictive strategy. So to know which one is an optimal strategy, that was really the rationale of the trial, together with the fact that transfusion can be also associated with some issues in terms of safety, but also has a cost and logistic issues in terms of supplies. So together with all these issues, we decided to design a non-inferiority trial in terms of MACE, which was our efficacy, primary efficacy outcome. And MACE was defined in our trial by total death, recurrent MI, stroke, but also urgent revascularization for ischemia. But also, besides looking to the non-inferiority of the MACE, we also looked to the cost effectiveness of these strategies. And the cost effectiveness, the primary outcome was the incremental cost effectiveness ratio, with MACE as the effectiveness criterion. The trial was designed as an open label, a randomized trial with two arms, liberal versus restrictive. All patients had to have an MI together with an anemia. And for the liberal strategy, patients had to be transfused as soon as they were randomized, with a target of hemoglobin of 11, while in the restrictive strategy, the patients were transfused only if their hemoglobin was 8 grams per deciliter or lower. And the target to achieve in the restrictive strategy had to be between 8 and 10. The study is a one-year study. The follow-up of the patients is for 1 year, but the primary outcome was at 30 days. And so the results that we presented at ESC are regarding the 30-day results, data. And so what we found was that we had 666 patients who consented to participate in the trial. And after randomization, the baseline characteristics of the population were similar. Patients were quite old, 77 years of age in both groups. 2/3 of them had a non-STEMI. And what we found is that first, in the restrictive strategy, there was only 1/3 of the population who had a transfusion, while in the liberal group, 99.7% had a transfusion. And the number of the units of blood which were transfused was saved by 55%, was lower in the restrictive strategy compared to the liberal. And together with a non-inferiority of MACE, 11% of MACE in the restrictive strategy compared to 14% in the liberal, and so with an hazard ratio of 0.79. And this is a non-inferiority trial, so what we looked at, of course, was the upper bound of the confidence interval, which was 1.18, and it met both the per protocol, but also the intention to treat analysis. And so we demonstrated in both analyses the non-inferiority in terms of efficacy of restrictive strategy compared to the liberal. Looking to the cost effectiveness, the ICER, the incremental cost effectiveness ratio, showed that we saved minus 33,000 euros per MACE averted. And when we looked to the joint distribution analysis of both costs and MACE, we found that the restrictive strategy had an 84% probability of being dominant, which means improving MACE and less costly. Regarding safety, because that's also an issue in terms of transfusion, together with, of course, the scarce of blood supply, etc. Safety is also an important problem. The overall safety did not differ between groups, so the restrictive strategy was safe. But we had a significantly lower rate, both of bacterial infection, but also an acute distress respiratory syndrome in the group of restrictive strategies. So altogether, looking to given the safety, given the non-inferiority in terms of MACE, given the fact that we used much less blood supplies, we could say that the restrictive strategy is the favorable arm to be used in patients who have an acute myocardial infarction and present anemia. Now, what remains to be done now that we have the demonstration of the non-inferiority clearly is to see if this strategy is superior in terms of MACE in these patients. Reality trial was not powered enough to test this hypothesis. We did it, of course. We did the analysis after proving the non-inferiority, but we were not powered enough and we didn't show any superiority, but that doesn't mean that there is not a superiority. We have to test it in a well sample size manner. And this is currently being done in another trial called MINT. And in this trial, which is done in the US, but also in Canada and soon in Europe, in particular by our own group, we will have the possibility of testing this hypothesis, and I hope that the results can be given in a couple of years. Thank you very much.